So we're going to be talking about orbital meningioma and what we should be doing from a neuro-op standpoint. And of course, the orbit is connected to your head. And so we've got the intracranial portion of the optic nerve, the intracanalicular portion, which is in the canal, the intraorbital portion, which is in the orbit, and the intraocular portion, which is in the eye. And so when we're dealing with an orbital meningioma, we need to know which direction it's going and what are the findings in the eye and what it means to get in the canal and what it means to get into the intracranial cavity. And it can go retrograde or it can go anterograde. And that's important for neurosurgery to help decide what to do. So the first thing is the intraocular presentation of the orbital meningioma. And the good news about the optic nerve is that it can either become pale or it can swell. And those are its only two pathologic responses. And that's also the bad news. It can either be pale or swollen. And if it's slow enough or hasn't been there long enough, the nerve can be normal. So it's a retrobulbar optic neuropathy that has an anterograde and a retrograde component, which is it can be swollen if it's pressing on the nerve, or it can be optic atrophy, or it can look normal. And so we're going to be looking for the differentiating feature, which is painless progressive loss of vision, visual field color vision, and an RAPD. And it doesn't matter whether the nerve is pale, swollen, or normal. You need to make sure this isn't an orbital meningioma. In the intraorbital component, if it's strictly in the orbit, that thing we call a sheath meningioma because it's only in the optic nerve sheath. And that one's important for neurosurgery because we don't operate that. So that's treated with either observation for progression, or if there's already progression, or if the goal is to save the vision, the primary therapy for orbital sheath meningioma is radiation therapy. Now, if the tumor happens to be one of these exophytic ones where it's going out here, you could debulk this section. But we really shouldn't be doing anything with the sheath because the sheath is where the blood supply is. And if you tear off the sheath with surgery, you're going to make the person worse. So we don't really do surgery on the intraorbital sheath meningioma. It's either nothing or primary radiation therapy. If it's in the canal, though, or intracranially, that's where we need neurosurgery. And as I said, it can be coming from your brain going in or coming from the orbit coming out. And so if it's from the sheath going into the canal, we're still going to consider primary radiation therapy. But if it's from the intracranial cavity going into the orbit, then you can debulk that with neurosurgery. And so that's the difference between a primary and a secondary orbital meningioma. If it's secondary from the sphenoid wing or from the intracranial cavity and it just went down the canal and into the orbit, neurosurgery can still debulk that component. And the role we play in that is to let neurosurgery know that sometimes you can't get there from here. So if it's got both an intracranial and an intraorbital component, it's going to be hard to get the whole thing out from just a single approach intracranial. And that's why neurosurgery has to consult with orbit and oculoplastics. And for a neuro-ophthalmologist, we have to image both the head and the orbit to see if the lesion is intracranial, intracanalicular, intraorbital, or all three. And if it's all three, that means you're going to have surgery on both sides of the orbital apex, and that means you need two surgeons. If, however, your goal is just debulking and it's intracranial, then we don't need the orbit. However, if it's got an orbital component and you can't get there from here and you don't want to operate on the sheath, then we might add adjuvant radiation therapy to the residual. So it's super important to recognize that orbital meningioma has both intraocular, intraorbital, intracanalicular, and intracranial aspects of the optic neuropathy that we have to take into account, that we need neurosurgery and orbit if it's in both. We need neurosurgery if it came from the head and went to the orbit, and we need radiation therapy if it's the sheath meningioma. Please don't operate on that. And you really can't tell which one of these it is just by looking at the person. You have to have an MR, head, orbit, gadolinium. And normally MR is our procedure of choice, but for meningioma, the CT scan is also helpful because the CT can show us the two extra things we need to look for: calcification, and that could make the Trantrac sign calcified here, or hyperostosis. And these two things are bony involvement, and neurosurgery is going to want to know about that because those features are very helpful both for the diagnosis of meningioma and also for surgical approach and completeness of the resection. And as you know, sometimes we can just make the diagnosis of sheath meningioma based on the MR and the CT combination, and we might go to radiation with no biopsy. And that means we don't need neurosurgery at all. So you need to know a little bit about orbital meningioma.